Today's meeting is not just a single topic, but I'm going to discuss the cases which I have encountered in last few months having severe mitral stenosis and posted for various surgeries. And recently, one of the case I have presented at GAR. So I'll start with that case. I'll present as it is, and then remaining cases I will discuss one by one. So recently, I have presented this case, that thoracic segmental epidural for LSCS in patients with a severe mitral stenosis. So if you background about this mitral stenosis in pregnancy is that around 0.3 to 3.5% of all pregnancies get complicated by the heart disease, and it's account for around 15% of the pregnancy-related mortality. And as you know that rheumatic mitral stenosis is most common, around 88% valvular disorders in pregnancy, and its outcome depends upon the severity of the mitral stenosis and the NIOHA functional classification of the patient. So the perinatal mortality rate in class 1 and class 2 amounts around 1%, whereas in class 3 and class 4, it may be up to 30%, depending upon the comorbid conditions. So it is too high. And the maternal complications, cardiac complications in the form of pulmonary edema and arrhythmias may be up to 2/3 of patients in severe mitral stenosis patients. So this is very high incidence of perinatal cardiac complications and mortality. So a few months back, I have encountered a 24 years female with full term posted for LSS. Actually, when she came in the casualty, there were two DIPs. DIPs means fetal bradycardia. So directly shifted to the OT, where we have evaluated in OT directly. She was having a dyspnea of exertion grade 2. She was a known case of RHD with severe mitral stenosis with mild pulmonary hypertension. She was on diuretics and she was undergone BMV, that is balloon mitral valvolectomy, 3 years back. Her vitals was okay with fairly acceptable limits. Diastolic murmur was there, but RS was clear. And there was some hypokalemia and hypovolemia on investigations. So we have informed the risk involved in the surgery to the relatives, and they have accepted grade 4 risk. And goals was to control the heart rate, because increasing the heart rate will definitely raise to trans-mitral gradient. And not only maintaining the low rate, but we have to maintain the sinus rhythm also, because the atrial kick is responsible for around 20 to 30% of the stroke volume. So maintaining the sinus rhythm is also very important. And the systemic vascular resistance also should not be fall precipitously, or sudden peripheral vasodilation should not happen. So that is one of our goal. Also, there should not be any fluid overload and maintaining the venous return. So on operation theater, we have just connected the cystoid to the peripheral IV line, and we have started the cardiac monitoring, inserted the central line for the monitoring of the CVP trend, not one just value, and for giving vasopressors. We inserted the arterial line through the left renal artery for beat-to-beat monitoring, invisible blood pressure monitoring, and for frequent ABGs whenever required. So we found that there was some hypokalemia, some acidosis. We have started correcting it, 20 milligrams potassium and 25 bicarb. And we have kept ready all these things, that is defibrillator, not just for the VTVF, but it's basically when patient goes into the atrial flutter fibrillation, we want to do it immediately cardioversion. Some vasopressors, we have already connected the noradrenaline, but for the intermittent bolus, phenylephrine is very much important, because the SVR should be maintained immediately. Antiarrhythmic drugs, beta blockers like esmolol, metoprolol are also kept ready. Esmolol causes fetal bradycardia also should be noted. If we use in the mother, we have to also keep watch on fetus to see the fetal bradycardia. Diuretics, inotropes, and other general anesthesia cart was kept ready. Antibiotic prophylaxis was given. And this is for all mitral stenosis patients, this preparation is must. And we have inserted the epidural catheter through T10-11 vertebral space, and space is obtained at around 4 centimeter. And we have further inserted this epidural catheter 5 centimeter cranially, so as to reach it around T10 spinal level, considering the vertebral spinal cord level discrepancy. So what is that discrepancy? As we go from cranial to caudal, the spinal segments and the corresponding vertebra, they do not match. There is a difference. As you go down, this difference increases. And at lower thoracic level, this difference is around 2 to 3 vertebral level. So from T10 vertebral level to reach T10 spinal level, we have to go 3 vertebra up. That means, and one vertebral height is around 1.5 to 2 centimeter in female. So we have to go 4.5 to 6 centimeter above. Considering the height of patient, we have threaded the catheter 5 centimeter cranially, so as to reach it around T10. So why T10? It is midpoint of T6 to and L1, which segment we want to block for the seizure. The patient made lie down and right buttock wedge was given, and graded segmental epidural was given with 3 ml dose with 3 minutes apart. And the dose was from the preparation of 10 ml of 0.75% ropivacaine and 1 ml, that is 50 microgram fentanyl. And slowly we have given with watch on the level and the hemodynamics. So we needed 9 ml of the total dose, and we achieved the level at around 6 to L2. That is just one segment more, and which is obtained at 16 minutes from the first dose. And why titration is needed? Because height of the patient doesn't matches with the dose required per segment. And also epidural space is reduced, and there is increased sensitivity of the local anesthetist during pregnancy because of the progesterone effect. And because of that, we need to titrate in. And also titration is needed for us in severe mitral stenosis patient because we want slow peripheral vasodilation. So SVR is maintained, so hemodynamic stability can be achieved. And with that, during the intraoperative period, we required the noradrenaline 3 to 5 microgram per kg. As the pressure goes down, we give a noradrenaline increased. We didn't give much crystalloid. Only 3 to 400 ml, around 400 ml crystalloid was given. And I have given ditor because patient was on ditor and urine output was around 150 ml in 1 hour. Immediately in post, noradrenaline is tapered off at the end of surgery, and we have removed the catheter to avoid any accidents. And the post-op analysis is maintained with the fentanyl patch and paracetamol. So what is the advantage of this thoracic segmental epidural over the GA and itself also? So there is a slow onset and it is titratable. So it is more cardiostable. By sacral sparing, the patient was actually moving the legs while doing the surgery because of the sacral sparing, and that is helps to maintain the venous return, and it is less thromboembolic also. And block can be extendable at desired level whenever we want. And there are distinct advantage of this epidural over the general anesthesia is that there is gastric aspiration chances as less. All the depressant agent, that is all polypharmacy, the drugs which we use in GA can be avoidable, that causes some myocardial depression and hypotension. And all the stress response can be avoided, like stress response of scopy, intubation, like that can be avoided. POM is definitely less. Disadvantage is the slow onset, but we want that slow onset. Block may be less dense, and because of that, we have added the fentanyl, not to increase the level, but to increase the denseness of the block. But fentanyl itself can cause some pruritus, which can be taken care of. Sacral sparing, yes, it is advantage also, but some disadvantage is that because of that sacral sparing, there is pain of while doing the urinary catheter, while swabbing at the end of surgery. That is there, but with the good communication with the patient, that can be managed well. So all the references which I have gone through regarding this segment epidural in LSS was through the lumbar level with bigger volume, and I have inserted through the lower thoracic level just to block only the desired segments, which reduces the amount of drug required, and the sympathetic blockage, which maintains the hemodynamic stability in seizure. So the segmental thoracic epidural anesthesia helps to titrate the minimum dose for the stable hemodynamics, and invasive monitoring in combination will help to assess the fluid and vasopressor requirement, and with both in together stable hemodynamics in seizure. So this was my first case. So with this, after a few months down the line, another patient came. That is a 47-year female. Same, the patient came with a pain in abdomen. She was also known case of rheumatic heart disease with severe mitral stenosis, and addition one more comorbid, that is a hypothyroidism. She was diagnosed as a upper ureteric calculus, and she was posted for PCN, that is nephrostomy. Her vitals was okay. The heart rate was somewhat more, but there was basal crypts and diastolic murmur. So patient was already on beta blocker Prolomet XL, was already on Ditor 20 milligram OD, and on Eltroxin for the hypothyroidism. So patient we have seen one day before in the evening. We have increased the diuretic dose, given the nebulization, whatever may be, because patient was posted next day morning because patient wasn't actually in pain because of the periodic calculus, and there was a gross hydronephrosis of the left kidney. So because of previous experience, this patient also we want to manage under the segmental epidural, but because of the economic constraints and the surgeon's requirement, we didn't put any invasive monitoring, no central line, no outline. Only two big cannulas was inserted. One is 20 and one another is 18 gauge cannula for the noradrenaline, and one is for the fluid. So epidural catheter is inserted at T11 and 12. We found LR at 4 and fixed at 8 centimeter. The same procedure, same preparation, same consent was taken as previous, as it is same mitral stenosis patient. So this time we have given same preparation, 3 ml incremental doses every 3 minutely. We required here also 9 ml dose. And the analgesia was T7 to L2, that is 8 segment after 15 minutes. Here we required the noradrenaline dose 3 ml, then we raised to 5 ml, and at the end of surgery, the patient becomes breathless. There was some initial tachycardia, then bradycardia. There was a hypotension, and we increased the dose of noradrenaline up to 8 microgram per kg per minute, and some volume, 50-60 ml volume was given at that point, because total volume we have given was around only 100 ml. Procedure lasted for 45 minutes, and slowly patient recovered. Immediately after giving the increase the dose of noradrenaline, patient stabilized. So the monitoring is not only the monitor, but the patient's clinical monitoring is also very important, and we should be very vigilant. What we have learned, the titration should be more slow and very patiently. This patient could be managed with the 6-7 ml dose, not 3 ml, but 2 ml incremental doses needed. And the most important, the vigilance and clinical monitoring is very much essential in such patients. So the same patient came for PCNL after 10 days, because we have just removed the pressure symptoms and drained the urine. Now the same patient came for the Percutaneous Nephrolithotomy for the renal stones. Now this time we have decided to do it under the paravertebral block. Same way, no invasive monitoring. 2 big cannulas was there for the noradrenaline and the fluid. We have assessed the paravertebral space with the sonography. Paravertebral space is actually a V-shaped space just lateral to the vertebra. That means medial to that space is the vertebral body and intervertebral foramen. Laterally, anterolaterally is the pleura, and posteriorly is the transverse process and the ligaments, that costotransverse ligament. The most important is the superior costotransverse ligament. So we have to pierce this costotransverse ligament so as our needle should go into the paravertebral space. So this can be done under the landmark technique or with sonography guided or assisted technique. So in 1 inch or 1.5 inch, around 2.5 to 3.5 centimeter lateral to the spinous process is marked at the desired level, and we have to give the local at that point. Then we have to hit the transverse process and just withdraw half centimeter, and then tilt cranially, and then till the loss of resistance we pierce the needle. This can be done under sonography also. I have done mixed. I have done just assess the level, assess the depth of the space, and the most important, depth of the pleura. The chances of pleural punctures are there if you exceed more than 1 centimeter than the transverse process. So after assessing this, inserted the catheter as 4 centimeter cranially again, and our aim is again same, T8 to L1 block. So we have inserted the catheter, and this catheter we have confirmed with the dye injection, because this paravertebral space is actually in continuation. So all the thoracic paravertebral places are connected with each other because of the pleura in front. But some RCT says that this space doesn't continue into the lumbar level. But some RCT says yes, it continues. And we have confirmed it, that you can see that with first dose, this catheter tip is here. Can you see my mark is here, exactly in between the T11 and T12 rib, and this is spreading above and below. And after the first dose, you can see very easily this dye is spreading in the lumbar level and going up also. And why it is spreading into the lumbar level? Because the same fascia continues as a iliopsoas on the iliopsoas muscle. So this dye also continues. So we have given the same preparation, 10 ml of preparation of 0.75 ropivacaine and fentanyl, 3 ml, 3 ml, 3 ml. We have given 9 ml and we waited, but there was very inadequate effect. Again, we have given 3 ml, 3 ml, 3 ml. Total 18 ml was required to block the T8 to L1 segment, that is 6 segments, and effect was seen after 25 minutes. So in nutshell, we required 18 ml drug. The effect from T8 to L1, we required 25 minutes. And the most important, the anesthesia we get, it's a complete anesthesia. Both somatic and visceral block was there. Other peripheral blocks are basically for the post-op anesthesia, but here this is an anesthetic block like epidural block. It's an unilateral epidural block, and there was a total stable haemodynamics. No noradrenaline was required. The surgery lasted for 90 minutes and nothing was required. during that procedure, I have not given sedation, and patient was absolutely comfortable and happy till the end of surgery and even in the post-op period. So the difference, because the same patient we have used for the paravertebral block and the thoracic epidural block. So patient as a control, we have compared these two blocks. So drug required in paravertebral block is 3 ml per segment, and in epidural is 1 ml per segment. The duration of onset is more than 25 minutes in paravertebral and 15 minutes in epidural. Hemodynamic stability is excellent in paravertebral block, and there was no need of vasopressors, but there was need of vasopressors in epidural. Urinary retention in PON is there is always a possibility, but there is no possibility in paravertebral block. And there are many references which I have gone, and I could able to retrieve only 2 references where they have given the paravertebral block for the PCNL, and then there was no reference I have found that they have given for the severe mitral stenosis patient. So I could able to put the reference in future. So the carry home message is that in the preparation we have to planning is very important. Not only this planning, but at the same time our planning should be extended to all our teammates, including mama, maushi itself. For example, in PCNL patient is prone, and suppose something goes wrong, immediately patient may need to be made supine. So trolley and everything should be kept ready. So all that your teammate should know what is the patient and what you are going to do and what you require. The segmental epidural anesthesia is better alternative to the GA. And whenever possible, the paravertebral block for the unilateral surgical cases like PCNL hernia can be used. The most important, the proper placement of catheter at the desired level is very much crucial, and the titration of patiently is must. And whenever you required, you extend the hemodynamic monitoring to an invasive monitoring modality for safe patient. And the most important, which I have not mentioned, the clinical assessment of a patient and monitoring during the surgery is at most important. You cannot rely totally on those monitors, but your own monitor, your pulse, your senses is really very important. Thank you.